The Radiology Review is pleased to offer the Board Exam Study Guide, episodes 1 through 101, available for purchase as a book on Amazon or in Kindle version. Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast. This episode focuses on the neuroradiology topics of epidural hematomas and subdural hematomas. I will release a free downloadable study guide on this topic at theradiologyreview.com. Reminder to follow at RadRevPodcast on Twitter or Instagram, where most days I'm currently posting information that may be helpful for board preparation. And a reminder to check out the current discount codes at theradiologyreview.com, where I frequently have discounts for things like online board review queue banks that could potentially save you some money on board preparation. Without further ado, let's get into the questions and answers for this episode. First question: what is the most common shape and what is the most common location of an epidural hematoma? And note that here I am preferentially using epidural hematoma, but this is also termed an extradural hematoma, and these could be considered interchangeable terms. The answer I'm looking for is that the most common shape of an epidural hematoma is biconvex, which is also termed lentiform. The most common location is the temporal region beneath the squamous portion of the temporal bone. Next question: what is the most common arterial source of bleeding with an epidural hematoma? I hope this is an easy one for many of you. The answer is the middle meningeal artery, which is the source of bleeding in about 75% of epidural hematomas. Next, approximately what percentage of epidural hematomas have a coexisting skull fracture? The answer here is also about 75%. So remember that about 75% of epidural hematomas are associated with a middle meningeal artery bleed, and about 75% of epidural hematomas are also associated with a skull fracture. Next, true or false? Epidural hematomas may also arise from venous bleeding. The answer here is true. In rare cases, a venous bleed, such as a torn venous sinus, including a vertex epidural hematoma with tear of the superior sagittal sinus, can cause an epidural hematoma. Next question: true or false? The extent of an epidural hematoma is limited by the venous sinuses. The answer is false. An epidural hematoma is able to cross the venous sinuses. Next, true or false? The extent of an epidural hematoma is limited by the cranial sutures. The answer here is true, at least mostly true and classically true. Exceptions do exist where an epidural hematoma does in fact cross a cranial suture. That leads us to the next question. In what settings is it possible for an epidural hematoma to cross a cranial suture? If sutural diastasis is present, the dura may extend through a suture, and this would allow an epidural hematoma to cross the suture as well. Sutural diastasis is most common in the young pediatric population. If a fracture disrupts and crosses the suture, this also is a potential route of spread of epidural hematoma through the disrupted suture. A venous extradural hematoma from disruption of the superior sagittal sinus can also be seen to cross the midline across the sagittal suture. These are some exceptions to the typical rule that epidural hematomas do not cross cranial sutures. Next, true or false? The extent of a subdural hematoma is limited by the cranial sutures. The answer here is false. As the bleeding occurs under the dura, the attachment points of dura to the cranial sutures do not limit the spread of a subdural hematoma. Next, true or false? The extent of a subdural hematoma is limited by the dural reflections. The answer here is true. Reflections such as the tentorium, falx cerebri, and falx cerebelli limit the spread of subdural hematomas. Next, what is the so-called lucid interval associated with an epidural hematoma? Most cases of an epidural hematoma have a traumatic event such as a motor vehicle accident, sport injury, or other hit to the head, followed by possible loss of consciousness. Afterward, the individual often regains normal consciousness, which is the lucid interval, and then gradually loses consciousness again over the next few hours, if the epidural hematoma continues to enlarge. Next question. What does the swirl sign suggest in terms of an epidural hematoma? The swirl sign suggests active bleeding at time of non-contrast CT imaging, and this is suggested when a swirl of blood is seen within the region of the epidural hematoma, in that acutely extravasated blood is slightly denser than the lower attenuation clotted and older blood products. This same principle holds true for extradural hematoma and intracerebral hemorrhage, in that acute bleeding can be seen as a swirl appearance within the larger hematoma. This can have implications for treatment, as the swirl sign suggests that the hematoma will continue to expand and mass effect is likely to progress, and therefore typically indicates a need for surgical evacuation of the hematoma. So the swirl sign is important to recognize, as is the implication that this is an imaging finding supporting active extravasation or active bleeding at the time of CT imaging. Next, what are leading features of mass effect resulting from an epidural hematoma? Leading features suggesting mass effect from epidural hematoma include midline shift and herniations, most commonly subfalcine herniation and uncal herniation. Next question. True or false? Abducens nerve palsy can be an early sign of downward transtentorial herniation. The answer is true. Abducens nerve palsy, usually ipsilateral to the epidural hematoma, can be a presenting symptom of transtentorial herniation. Next, true or false? Non-traumatic causes of epidural hematoma exist. The answer is true. Bleeding from vascular anomalies like an arteriovenous malformation can result in epidural hematoma formation. Next, true or false? Non-traumatic causes of subdural hematoma exist. The answer here is also true. Bleeding from intracranial hypotension, vascular malformations, coagulopathies, and some leukodystrophies can cause non-traumatic subdural hematomas. So remember that non-traumatic causes of both epidural and subdural hematomas do exist. Next, what is the classic shape of a subdural hematoma? Subdural hematomas are classically sickle-shaped, also termed crescent-shaped, which is in contradistinction to the classic biconvex shape of an epidural hematoma. If you don't know exactly what these look like, please look up images and make sure you are aware of the differences in appearance of a classic epidural and a classic subdural hematoma. Next, what is the underlying classic mechanism that causes a subdural hematoma? The answer I am looking for is tearing of bridging cortical veins. This is the classic mechanism of subdural hematoma and causes subsequent bleeding between the arachnoid and dura. Next, true or false? Most subdural hematomas are bilateral. This is a tricky question, and I would say that the answer is true and false. In adults, nearly all subdural hematomas are unilateral. However, in infants, most subdural hematomas are bilateral. I think that is important to remember that subdural hematomas are typically unilateral in adults and bilateral in the pediatric population, especially infants. Next, a subdural hematoma in an infant without definite etiology, such as motor vehicle collision, raises consideration for what potential important etiology? The answer I'm looking for here is that a subdural hematoma in an infant without other definite cause indicates evaluation for non-accidental trauma. Of note, an isolated parafalcine or interhemispheric subdural hematoma is commonly seen with non-accidental trauma. Next question. What is the most classic etiology for subdural hematomas in the elderly? Falls in the elderly often lead to subdural hematomas. Repeated falls over time can cause a complex appearance of a subdural hematoma with varying densities due to varying ages of clotted blood. Note that subdural hematomas can be a cause of pseudodementia in the elderly. Next, what is the classic CT attenuation for hyperacute, acute, subacute, and chronic subdural hematomas? What I am going to present here is a simplification, but for board exam purposes, the following may suffice. Hyperacute would be isodense to cerebral cortex with the swirl sign present. And again, this is the CT attenuation for a subdural hematoma. So hyperacute, isodense to cerebral cortex with swirl sign present. Acute, hyperdense to cerebral cortex. That is hyper. Subacute, isodense to cerebral cortex for the first few weeks following bleeding. And chronic, hypodense, hypodense to cerebral cortex. And the chronic phase is generally considered to be 3 weeks and beyond. Peripheral calcification around the subdural hematoma can ensue. Next question. If an acute subdural hematoma is isodense to the cerebral cortex, what underlying condition does this suggest? This is a slightly more advanced topic, but remember that I just told you that the typical appearance for an acute subdural hematoma is to be hyperdense, hyperdense to cerebral cortex. If, however, an acute subdural hematoma is isodense to the cerebral cortex, this can be reflective of things like anemia with low hemoglobin, current anticoagulation, and coagulopathies causing poor coagulation. The key here is that the coagulated blood in the acute setting is generally hyperdense to cerebral cortex. Next question. True or false? Cerebrospinal fluid may also mix with blood products in a subdural hematoma. The answer here is true. As the arachnoid is often torn in a subdural hematoma, CSF often mixes with the blood products, which can be one cause of mixed echogenicity within a subdural hematoma collection, along with clotted and unclotted blood products. Next question. What are key features of a subdural hygroma? That is Hygroma. A subdural hygroma is fluid in the subdural space, which is likely cerebrospinal fluid that accumulates. This can coexist with a subdural hematoma. Subdural hygromas can be idiopathic, post-traumatic, or can result from intracranial hypotension. That is HYPO, hypotension. This may result from a tear in the arachnoid, which allows CSF to leak into the subdural space. On imaging, these appear as near CSF density subdural fluid collections. Key imaging features to tell a subdural hygroma from a subdural hematoma are first, cortical veins that cross through the collection on contrast-enhanced imaging. If you see cortical veins uninterrupted and without mass effect crossing through the near CSF density collection on a contrast-enhanced scan, that is a subdural hygroma most likely. If mass effect is seen on the vessels, however, this is more consistent with a subdural hematoma that is demonstrating near fluid or CSF density. Second is using FLAIR sequences on MRI to show that the hygroma has slight signal difference from pure CSF, typically being slightly more T2 hyperintense than CSF. Other entities, like an arachnoid cyst, would follow CSF signal on all sequences. Last and final question for this episode. What is the itty bitty baby doo-doo mnemonic? This mnemonic can help you remember how different ages of intracranial bleeding classically look on T1 and T2 weighted MRI sequences. The key is first to remember the 5 stages of blood, meaning hyperacute, acute, early subacute, late subacute, and chronic, and that the first letter in each pair is for the T1 appearance and the second is for the T2 appearance. So again, you need to remember that there are 5 stages of bleeding, starting with hyperacute, acute, 2 forms of subacute, so you have early and late subacute, and finally chronic. If the mnemonic has an I in the key portion, that means iso-intense, B means hyper-intense, and D, like dog, is hypo-intense or dark. B is hyper-intense or bright, and I is iso-intense. So let's start. First, it, B. Notice the I and the B, and that tells you that in the hyperacute setting, blood products would be expected to be iso-intense, it, on T1, and B, bright or hyperintense on T2. Itty is ID, DY. So I tells you that in the acute setting, blood would be iso-intense on T1, and D tells you dark or hypo-intense on T2. Biddy tells you early subacute is hyperintense or bright on T1 and hypo-intense or dark on T2. Baby is late subacute, and this tells you that both are B or bright, meaning bright on both T1 and T2. And then finally, doo-doo. You have 2 Ds, and this tells you that in the chronic setting, the blood products would be predicted to be hypo-intense or dark on both T1 and T2 weighted images. If you need to review that in writing, feel free to Google, and it will quickly bring it up at various sources, or download the free study guide at theradiologyreview.com. That concludes this quick review of neuroradiology, epidural hematomas, and subdural hematomas for board preparation. I hope this was helpful for many of you. Remember that other podcast episodes and study guides are available at theradiologyreview.com. I want to take a moment to let you know that depending on what podcast platform you listen to, all of the available episodes of the Radiology Review podcast may not be instantly available. If that is the case, for example, many times Apple Podcasts has only had the most recent 100 available for immediate download. You can certainly access all episodes at theradiologyreview.com. There are also hyperlinks in the podcast description that you can click on to, for example, sort all of the episodes by neuroradiology or body imaging or breast imaging, for example. You can sort the episodes by topic or subspecialty on my website, theradiologyreview.com. That's all for now. Keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.
What's better than listening to the Radiology Review?
Nothing.
Well, true. But you could buy our book, The Board Exam Study Guide, Episodes 1 through 101, available for purchase as a book on Amazon or in Kindle version.